Hi everybody, my name is Rebecca Morris. I'm a research fellow at the NIHR Greater Manchester Patient Safety Translational Research Centre, and today I'm going to talk about a project that I've had the pleasure of leading where I've co-developed a patient safety guide with GPs, pharmacists, patients and carers. And today I'm also presenting with Gallacher, who is a public contributor and the public contributor lead for the patient safety guide. And we're going to split the presentation. So first of all, I'm going to present using PowerPoint, a little bit of background about the guide and where the actual project came from and the approach we've taken. I know a lot of people talking about co-design over the festival, which is wonderful, but also that can be interpreted in different ways. So I'm going to talk a little bit about that. And then I'm going to pass over to Kay, who is going to talk about her experiences and her reflections on being involved in co-design and what she's learned from that. And then she'll pass back to me and I'll bring the presentation to a close and also reflect as a researcher what are my experiences of co-design. Brilliant. Okay, so we're talking today about co-producing a primary care patient safety guide for patients and carers. And this guide is actually a multi-component tool. So we have a paper version, but we also have a mobile application for both the Android and Apple devices, and a support package to support its use in primary care, both for patients and carers and for healthcare professionals. So the aim of this session really for us was just to describe what we've done and reflect on that. So the guide aims to help to address key patient safety questions and identify key points where people can make their care safer. But first of all, let's think about, well, what do we actually mean by patient safety? Well, patient safety can be defined as the avoidance, prevention and amelioration of adverse outcomes or injuries stemming from the processes of healthcare. And we can look at that at lots of different ways and lots of different levels, but I've been particularly interested in thinking about, well, what does that mean for patients in their patient safety? And if you think about that in terms of, for example, diagnosis, this can mean, well, what information does somebody think to tell their doctor or nurse to inform a diagnosis? And importantly, what information do they leave out? What do they think isn't relevant? We can think of examples with treatment and management. Again, we can think about, well, not only what is said in a consultation about what should be done or what can be done, but what do people take away from that? What do they go home and importantly do when they get at home and they're on their own? And as you can see here, I'm talking a lot about communication and the importance of that, excuse me. And if we think about, well, is this new? How have patients traditionally been involved in patient safety? Well, primarily they've been involved in the identification of errors, but there's been a real shift to actively involving patients and carers in the prevention or reduction of incidents. And that's where the guide fits in. So it's not enough just to tell people they should be involved in their patient safety. You need to develop tools and support to enable people to do that if they choose to. And so we developed the guide to address those key patient safety questions and identify key points where people can make their care safer. And we did this using an adapted version of the experience-based co-design approach. And again, I think across the presentations, people may have talked about this, but just from my perspective of what we did, well, key to this approach is firstly, it's about sharing experiences. So understanding the experiences of healthcare from different perspectives, the patient, the carer, and the healthcare professionals. And by bringing people together to share their experiences and their different expertise, we considered, well, how did the service perform? How does it feel? And how usable it is. And not only did we think about the experience part of going for care and how that informs safety, but we thought about, well, actually, how do we turn that experience into action? And that's where co-design comes in. And really, the underlying principle here is to work in collaboration with people who will be the end users of the intended initiatives. And I love the picture that's on the screen at the moment, because I think we've all experienced that, where beautiful design, you know, we have pavement or whatever, and actually we're all looking for that shortcut or that workaround that works more effectively and efficiently for us. So what did that actually really look like? Well, we worked together in a series of teams. There was a core guide team, and we had a number of involvement groups. We had patients and carer public involvement group. We worked with GPs and pharmacists in a stakeholder group to inform the beginning of the project. And then we ran a series of co-design events. And very much we started with a blank piece of paper to go on to look at, well, what should we develop? And that led us on to thinking about the guide, also developing a website, the app, and different little things to support the guide along the way. So this was an iterative process. So that means we kind of went round in circles and built on our discussions. So we kind of looped back and kind of kept building to make sure what we were doing worked for the different stakeholders involved. And as I said, we pretty much started with a blank piece of paper, and we were really lucky to have visual note takers with us, and they captured some of the discussions that we had. And I think the biggest issue really that came out was communication. And across different settings, whether going into pharmacy or general practice, there was this issue about not being certain about what to say or not who to say it to, and also about whether privacy and different things. And I think key to these discussions was this issue of responsibility. There's a responsibility on behalf of the service to ensure patient safety, but also patients can have a role in that. And so where do we go next? Well, we've developed the guide, and as I say, that's a package of tools. It's got an app, it's a paper-based version, and there's a website to support the guide. And we're now in the middle of testing that. Obviously, COVID has thrown up a few curveballs, and we've adapted the guide in response to changing care. And I think that's been really important, that it was able to be adapted and be responsive to that change. And now we're also starting to think about how we can adapt the guide to think about how it might work for different populations who might have different needs. So now I'm going to hand over to Kay, who's just going to reflect on her experiences as being a public contributor as part of the guide project.
Hi, I'm Kay Gallacher. I've been a public contributor for the last 7 years with the Faculty of Biology, Medicine and Health at the University of Manchester. During that time, I've taken part in around about 30 research projects and sat on various forums and meetings. The Patient Safety Guide is the first co-designed project that I was involved with. When I heard about this project, I was intrigued. Developing and testing a guide for the public to help them stay safe in primary care sounded so fascinating, and was one of those things that you wondered why it hadn't been done before. I also liked the fact that it was a true piece of co-production involving public contributors, GPs, pharmacists and other researchers, with a real-world application at the end. I felt that I could add my own life experiences and could help shape the project and make it acceptable and useful for everyone. The initial workshop was run by Becky with about 25 people attending, a mix of members of the public like me, pharmacists, GPs and 1 or 2 researchers. We sat at mixed tables and debated things like what sort of information should go into the guide, what it should look like, who might use it, what it should be used for, what the format should be. And you can imagine that everyone had their own take on all of these things. The GPs were concerned that a greater burden would fall on their admin staff and that people using the guide would need longer appointments. But on the whole, they were in favour of it, as were the pharmacists. I was quite concerned in this first workshop that the professionals were going to take over and the public contributors would either not get a word in or wouldn't be taken seriously. After all, GPs in particular are used to offering advice and expecting that their advice is going to be taken. However, in true co-design style, we all had our say, we all offered our views and was listened to. even if things did get a little bit heated in parts. The workshop was really well run. Becky threw in several issues for us to debate around the tables, and then each table's collaborative view was posted on a board. There was another board where we were all able to put our own individual views on post-it notes. I came away from the workshop definitely feeling that I'd influenced the project and had my say. Following the workshop, the project then continued with a group of public contributors steering the design and the function of the guide. In my view, this method just proves the saying that the sum of the whole is greater than the sum of the parts. Of course, there are some downsides to co-design. It's not easy to do, and it's definitely not easy to do well. I'm afraid that some researchers still simply do lip service to co-design, thinking that because they've run a workshop and asked members of the public for their thoughts, that they can label it co-design. To do it properly, it has to be a complete joint effort all the way along from inception to fulfilment. The researcher may be the one organising things and setting the agenda in the first instance, but then there's total involvement from everyone else. Co-design and co-production certainly take time, and these projects often run longer than traditional method projects, so I'm sure they can feel a bit tedious. Constantly getting consensus from a group of individuals can be challenging and draining, especially for the researcher, who after all still has responsibility for the project, its budgets and its outcomes. But in the end, in my opinion, a well-run co-design project almost certainly produces a better, more cohesive and useful piece of research.
Thanks, Kay. I think that was really important reflections on the process and where we've come from to where we're going as well. And how actually bringing everyone together, while on paper is a great idea, you do have to think through how to make sure everyone's voices can be heard and how people can feel confident to speak up and think about those sort of traditional power dynamics in discussions and things like that. And for me, that was a really important part of doing a co-design approach and project, that by bringing everyone together, by allowing everyone to have the opportunity to voice their experiences, we could really work together to think through what it was that we were going to develop, and then what that could actually look like in reality that would be useful to people from different angles. Because it's nice to create something that works for one group, but if particularly when we're talking about something that's around communication, if it only works for the patient group, for instance, and there's a lot of barriers maybe with the GPs or vice versa, then it might not get implemented, and that would be a real shame. So actually bringing everyone together, we could have those discussions, and like I say, they were iterative, so we kept building on them through the number of events that we did. And outside of those events, lots of work happened to support the development of prototypes that we could take back to see if we'd interpreted what had come out of the discussions correctly. And actually, I think we all know that feeling of thinking what we want, and then we get our hands on it and it's not quite what we expected. So we were able to refine, and that process of refinement took quite a while as well, but was so worth it, so that the actual product that we have, I think, is much more useful for it and is a real value, I think, for the co-design approach. And I think just one thing to mention towards the end really is that the sessions were all co-facilitated. So we had a member of the research team on every table in the discussion, but we also had a member from the public involvement group who worked with us to run each table. And again, I was very conscious going into those sessions that it didn't want to be the researchers leading the conversation, that it was always a partnership, and it was a partnership all the way through. And I think that was really important, and one reflection that I think I say to everybody that does this is to think about, well, how can you support people to take on different roles in that sort of event. And finally, just to say that we're now at the point of testing the guide, and it's been tested over the last few months, and fingers crossed in the next few weeks, couple months, we should be at the point of being able to share some results from that and think about how actually people who weren't involved in the development of the guide, what they think of it, whether they find it acceptable and useful. Thank you very much.